Renal arteries are stenosed, either one or two. There are two main type of renal artery stenosis, one in a younger person, the other one in the older person. Younger person, it is fibromuscular dysplasia, it is usually females, while the other one is atherosclerotic narrowing, which is seen in older age group. So these are two main type of renal artery stenosis, and then you can have other ones. There may be external compression, there may be renal artery dissection, radiation fibrosis, obstruction of a graft. अगर आपने aorta में, if you put in a graft in aorta, that may obstruct the artery. So these are very unusual reason of the renal artery stenosis. The most other one are atherosclerotic and fibromuscular dysplasia. Now what will happen when there is diminished, when there is renal artery stenosis, there is slow perfusion or decreased perfusion of the kidney. That decreased perfusion will result in the hypertrophy of the juxtaglomerular apparatus. What does juxtaglomerular apparatus do? It produces renin. Now why this happens? Because the kidney perceives that as compared to the circulatory space, the circulatory volume is low because there is small amount of blood going to the kidney, although the circulation is full. But the kidney is perceiving that as compared to the vascular space, the volume is less. So the juxtaglomerular apparatus starts pouring out renin. The renin starts converting angiotensinogen to angiotensin 1, which is converted to angiotensin 2, and the blood pressure starts rising because angiotensin 2 causes vasoconstriction, it causes production of the aldosterone, which causes sodium retention. And in addition, the angiotensin 2 is also a very strong stimulus for what? Vasopressin. So the vasopressin also starts increasing, so the volume starts increasing. And since this condition is a sort of permanent thing, so you have a permanent rise in circulating volume, that means the cardiac output starts increasing, and because of the angiotensin and vasopressin, there is vasoconstriction. So the both phenomena go on. Peripheral vasoconstriction, peripheral resistance increases, circulating volume increases, the blood pressure starts rising. So it can lead to volume overload, heart failure, and pulmonary. These are the diseases association with atherosclerotic disease. They are not with fibromuscular dysplasia. Presentation is abrupt onset of hypertension. If it is in a younger patient, this is fibromuscular dysplasia. If it is an older patient, this is atherosclerosis. The hypertension is resistant or malignant. You keep on adding drugs, the blood pressure does not respond. The ordinary essential hypertension does respond to treatment. This blood pressure does not respond. So one feature is abrupt onset of blood pressure. Second is it is non-responsive to standard treatment. And then the other features are the renal function that worsens. If you give patients ACE inhibitors, the renal function may worsen if there is bilateral stenosis. And if there is unilateral stenosis, what will happen if there is unilateral stenosis? If there is unilateral stenosis, the blood pressure rises, it causes pressure natriuresis. So patient will have hypertension with hyponatremia. Volume is increased, sodium is being lost, and patient will have hypertension and hyponatremia, which is not seen in other type of hypertensions. And if there is bilateral renal artery stenosis, if you give these patients ACE inhibitors or ARBs, the creatinine rises. So this is another presentation. So any patients who is younger and hypertensive, you start ACE inhibitors or ARBs, you have to monitor the creatinine. If the creatinine rises, it means the patient has problem in the renal circulation. So this is the main presentation of renal artery stenosis, and then you can have presentation as hypertensive emergencies, like patient may have acute rise in hypertension producing flash pulmonary edema. There may be hypertensive encephalopathy. So these presentation may be there. Hypokalemic alkalosis is one presentation of this thing. Physical examination, it may show hypertension. There may be renal artery bruit. Renal artery bruit is, where do you hear renal artery bruit? Where is the renal artery? अब मेरे सवालों का जवाब तो देते नहीं हो कोई. What is the level of origin of renal artery? Where is the renal hilum? It is in the transpyloric plane. Where is the transpyloric plane? It goes through L1. Now, how can you locate transpyloric plane on the body? It's not easy. You cannot locate it. So you take its subcostal plane. Subcostal plane is slightly higher than the transpyloric plane. So you take the subcostal plane, and you can hear the renal artery bruit in the epigastrium, because it arises at this level and it's either on the slightly left side or on the right side, depending upon which artery is involved. So you hear the renal artery bruit in the epigastrium. You may also hear in the flanks. So look for the presence of renal artery bruit if the patient has developed suddenly hypertension after the age of 50 years or before the age of 20 years. So you go for renal artery bruit examination. Patient may have edema because of the volume overload. Investigations. Imaging is the most important investigation which tells us that this is renal artery stenosis, and ultrasound is the investigation of choice. It can tell you the discrepancy in the size of kidney. The kidney which has got lower supply will be atrophic, hypoplastic, the other kidney will be big. So you have to see, ultrasound is the best investigation for initial screening purposes. And ultrasound using a duplex method can also tell you the flow through the renal artery. What is the flow through the renal artery? So ultrasound is the important investigation. You go for CT angiography if there is normal renal function and you suspect renal artery stenosis and it's not clear on ultrasound. For example, patients who are older, they may have normal size kidney because the kidneys have already grown to their normal size. In a younger patient, when there is fibromuscular dysplasia, the kidney may be atrophic. But in patients who got atherosclerosis, both the kidneys may be of normal size. And if you suspect that this may be renal artery stenosis, depending upon the patient's presentation, you can go for a CT scan if the renal function is normal. If the renal function is not normal, you can go for MRI examination, MR angiogram. CT because you require contrast medium which can affect the kidneys. So if there is kidney dysfunction, don't use this. The labs, we go for routine labs like creatinine, electrolytes, lipids, lipids for atherosclerosis, ESR, CRP for vasculitic disorders. For same reason we do complement. If there is elevation in the creatinine, the likelihood is that is associated atherosclerosis is there. Normal creatinine with fibromuscular dysplasia. Plasma renin aldosterone ratio is required. Why we need plasma aldosterone and renin ratio? Because these patients have renin and aldosterone which is high. So why we need this ratio? We have to rule out Cone syndrome. What will happen in Cone syndrome? Cone is primary aldosteronism. So the aldosterone will be high, the renin will be low. While in this condition both will be high. And if you check angiotensin, that will also be high. So in this condition we have both high, while in primary aldosteronism, aldosterone will be high, the other will be low. So we need that. Metanephrines to rule out the FeO, and free cortisol to rule out Cushing syndrome. Urine protein to assess renal function, and you can go for other urinary examination. For example, if there is glomerulonephritis, you may have hematuria, red cell cast, there may be protein cast. So you look for the presence of proteinuria. Other investigation, we may go for catheter angiogram. This is generally not required if we've got a good sonology and CT scanning. This generally is not required. This is sometimes required when we want to do renal surgery, and we have to be sure that removing the affected kidney will help us controlling blood pressure. So for that, what we do is we selectively catheterize both renal veins and take the samples and see how much renin is being put by the kidneys individually. If a kidney is putting a large amount of renin, the other one is not producing renin, it means removing that kidney may be useful. So it's done in exceptional circumstances. Differentials are essential hypertension, primary aldosteronism, obstructive sleep apnea. Medical treatment is ACE inhibitors or ARBs. Contraindicated in bilateral renal artery stenosis. When you are suspecting that both kidneys are affected, start some other drug, not the RAS drugs. Or especially if a patient has one kidney and it is stenosed artery, you don't start this. If you have got two kidney, one is stenosed, you can start ACE inhibitors or ARBs. But if both are stenosed, don't start ACE inhibitors or ARBs. Or if patient has only one kidney but that is stenosed, don't start these RAS drugs. They are going to cause deterioration in renal function. You can choose calcium channel blockers or beta blockers. Surgical treatment is revascularization. If patient has severe complications of renal artery stenosis, there is unexplained heart failure, there are multiple episodes of unexplained pulmonary edema, patient has unexplained chronic kidney disease, and the blood pressure is not being controlled on conventional drugs, you think of renal artery stenosis and you may go for surgical treatment. Surgical treatment may not improve outcome in those who got atherosclerosis. The result is very good in fibromuscular dysplasia. In atherosclerosis, the problem is that multiple branches of the renal artery may be involved. So surgical treatment of one may not be effective. So you have to do treatment in multiple segments of renal artery branches. Cures up to 58% hypertension in patients who got fibromuscular dysplasia. There may be contrast-induced injury to the kidney. There may be allergic reaction. Patient may have bleeding, hematoma, or patient may have arteriovenous fistula formation because of these catheter procedure. So these may be the complications of renal artery stenosis. So this is about renal artery stenosis in brief. So if you have any question about this disease. So the take home is that if in a young patient or in a very old patient, blood pressure develops suddenly, think of it. If it is not responding to 1, 2 or 3 drugs, think of this thing. If patient has unexplained pulmonary edema, think of this thing. If the patient has unexplained heart failure, consider this is. And if there is unexplained rise in creatinine after you give ACE inhibitors, think of renal artery stenosis. Otherwise, renal artery stenosis in hypertensive patients is not a very common condition. Okay.